for inviting me and for giving me the possibility, the opportunity to present this ongoing work. What I'm presenting today is actually two parts, divided into two parts, two works. Both works are joint works with Bruno Arpino from the University of Florence and Giorgio Di Gessa from UCL. The reason why I decided to present both works together, although they are somehow different, they rely on different data and they address different questions, is that I think that somehow they help us to better understand the role of a family, of close relationships in these difficult times, in terms of its effects, both beneficial effects, but also possible negative effects in times of a pandemic. So both works are ongoing works. One is published in a preprint version, and the other one is still work in progress. So somehow both have possibility of improvement, and that's also why I'm happy to present these works, because I'm very much looking forward to your comments about what we are doing here. So as a general background, as a general overview, the starting point is that, especially very early in this pandemic, there have been clear recommendations for older people to avoid physical contacts. Older people were advised, and sometimes even forced, so to say, to stay at home with different regulations in different countries. But everywhere there was this general message of avoiding as much as possible physical interactions, and especially for older people to avoid physical interactions with, for example, their grandchildren. The reason behind is what we by now all know, that physical closeness is a necessary condition for the spread, for the transmission of a virus. And the focus on older people derives from the fact that with higher ages, there has been an increase in the risks of serious illness and of death. Having said this as a general background, we come more to the point of our investigations, which is the fact that these reductions in physical contacts often meant the reduction, the limitation of an important role in later life, that is grandparental childcare provision. Here we come to the very first study I mentioned in the previous on the previous slide, and we need a little bit more of a background for this. Why do we focus on grandparents? Why is there an interest in there? The reason is that we know from pre-pandemic surveys, from pre-pandemic studies, that grandparental childcare is very common in most of the European countries. So on average, more than 50% of both grandparents and grandmothers declare to look after at least one of their grandchildren, with different percentages across countries, with different frequencies. So we have heterogeneity in this kind of supportive role, but in a sense, we do see the relevance of this role for older people in most of the context. With the pandemic, as I already mentioned, there was this advice not only to stay at home, but also to avoid physical contacts and to avoid contacts with grandchildren, which, especially in the very early stages of the pandemic, were identified as super spreaders, more likely to have very little, if no, if at all, symptoms, and to bring somehow the virus further. At the same time, there has been some research focusing on the consequences of this staying at home, of this avoiding physical contacts in general, not with a focus on grandparents. And these kind of studies have found that there have been somehow negative effects associated with these well-meant policies, and negative effects in terms especially of mental health. So what we thought is to sort of combine these two line of research and try to understand whether there is any whether there has been any change in grandparental childcare during the pandemic, and whether this kind of changes may have affected the mental health of the grandparents. So somehow linking the research on contacts, on interactions between grandparents and grandchildren, and support provided by grandparents. On the other side, looking at the health outcomes deriving from this kind of changes. To do this first part of research, we have used data from ELSA, the English Longitudinal Study of Aging. You might be familiar with the study. Here it is worth to mention that in addition to the longitudinal biennial survey that has been carried out since many years now, over 2020 there have been two so-named COVID-19 waves. So focusing exactly on pandemic aspects, changes from pre-pandemic to pandemic times in several behaviors and aspects of life. The focus remains on individuals age 50 plus living in private households in England. What we do is to use the second COVID-19 wave and to combine this with information of the most recent pre-pandemic data, so the wave 9. We keep people who are grandparents with at least one grandchild up to age 15, because this is the group which was exposed to questions on grandparenting, and who have no missing data on grandchild care during the pandemic. We come up with a sample of about 2,500 grandparents, and we run both logistic and linear models depending on the outcome variables on this sample. What is very important here is that our work always controls for baseline characteristics, meaning that we take into account the condition of the respondents before the pandemic, so at wave 9, in order to analyze whether the changes in grandparental childcare might have an effect on the situation, on the outcomes in pandemic times. I spoke a bit broadly about variables and effects. In practice, what we do is to look at grandparental childcare in terms of whether grandparents looked after grandchildren without the presence of the parents, and in particular we use the questions that investigate whether there has been a change in the amount of time of grandparental childcare as compared to pre-pandemic times. Here respondents had the chance to report that they decreased, they stopped, they increased, or they maintained the same level of grandparental childcare. In terms of mental health, we look at depression, quality of life, and life satisfaction. So somehow we take a broad approach on the definition of mental health, including well-being aspects as well. All the measures that we consider were measured in the same way in the pre-pandemic wave, so wave 9, and in the pandemic waves, in the COVID waves, so that we can have both of them inside. All the analysis I will present, actually, I will make it very concise, but we should keep in mind that everything we run in these models also controls for a series of usual suspects, so the social demographic characteristics of respondents. So we have grandparents' age, sex, ethnicity, income, wealth, education, employment, home tenure, pre-pandemic disability and mental health, and then in terms of relationships with the grandchildren, we have the distance to the closest grandchild, number of grandchildren, and age of the youngest grandchild. We also take into account household composition, social contacts, and loneliness. So 3 aspects that might tell us something about networks and engagement or social aspects of the respondent. What we see here, I think, is somehow the answer to the first question. So we don't need fancy analysis or regressions to see what changed. Actually, let's just focus on the darkest part of these bars. What we do see here is that as compared to pre-pandemic, we have that in June 2020, about 53% of grandparents have stopped doing grandparental childcare. So we start from February 2020 with, in February 2020, we had about half of the grandparents providing grandchild care. And then a few months later, mostly due to the first lockdown measures, we had 53% of grandparents who previously provided grandparental childcare who actually stopped that. As you can see, this dark bar, the first one, is the longest one. When we jump to the following periods, so to June, August 2020, or to September, November 2020, so summer and autumn, we have again between 30 and 40% of grandparents who stopped looking after grandchildren. But you see the reduction has been a bit less as compared to the very beginning of a pandemic. Here, we should interpret the results in a more complex way that we can actually analyze. In the sense, we should think back at what were the policy measures at the time. So March, June, we had lockdowns. Later, there has been the measures have been relaxed, and then in autumn there has been a new wave of a pandemic, and that's why probably people somehow reduced further the engagement in grandparental childcare. We do have also people who maintain the same level of grandparental childcare. Some decreased it but did not stop it, and a little percentage, which never goes above 10%, even increased grandparental childcare. Obviously, we have also a variety of family constellations, and we should never forget that there are also people who had jobs or have jobs that did not allow home office, that in cases of school closures needed help from grandparents, but indeed a large proportion of grandparents who previously engaged in grandparental childcare declared to have stopped this engagement. And now we come to the analysis on what did this mean in terms of mental health and well-being. Here we ran a series of models, and we included all the controls I mentioned before. But as I said, the story is very clear, is very robust to various models. What it's of interest for us is indeed what you can see in this red box on the slide. Those who completely stopped doing grandparental childcare, controlling for pre-pandemic mental health and physical health conditions, also faced an increase in depressive symptoms, a decrease in quality of life, and a decrease in life satisfaction. As I said, these results were very much robust to different kind of modeling, and the story came out very clear from the beginning. So what we could see here is that people really followed the advice to reduce physical contacts, and in particular in case of intergenerational relationships, with 1 in 10 grandparents who completely stopped providing grandchild care at various points during the pandemic. But at the same time, what we could see here is that compared to grandparents who increase or maintain unchanged their provision of grandparental childcare, those who stopped completely engaging in grandparental childcare were more likely to report depressive symptoms, to report a reduction in quality of life, and a reduction in life satisfaction. What we understand from this kind of analysis is that, of course, we need measures to limit the spread of a virus, and of course, reducing the amount and the frequency of physical contacts is and was an immediate answer to the need of keep the virus as limited as possible. But we should not forget that the measures that are taken to contrast the virus may also have other direct or indirect effects on the people who are affected, and that these effects might be heterogeneous across the population. In the case of our study, we could find potential adverse consequences of reduction of an important engagement in later life for older people's mental health. There might be also other aspects in this that needs to be taken into account in order to address possible subgroups of a population differently as compared to others when we need to answer a global, a society challenge. But what I said so far was somehow taking into account aspects of family solidarity that are positive for older people, but that they might be negative for other kind of aspects. So, for example, higher contacts, physical contacts between grandparents and grandchildren, they might spread further the virus and therefore not be advised in times of a pandemic. But we should not forget that having a close networks, having kins, having support and solidaristic relationships within the family may also help limiting the spread of a virus. How? I'm going to tell you now in elaborating more about this slide and the next one. Early in the pandemic, and here I'm talking about spring 2020, there has been an argument that at the time, Italy had a very high prevalence of COVID-19, mainly due to its high prevalence of intergenerational co-residence, contacts, relationships. When we read that, Bruno Arpino and I thought that was a bit too simplistic to take it as truth. Indeed, at the time, it's true that Italy was very hardly hit by the pandemic, but northern regions were much more affected by COVID-19 than southern regions. And it is well known that in northern Italy, family relationships, family solidarity are somehow weaker than in southern regions. So if that argument, if that hypothesis would have been true, we should have expected the opposite once within country analysis would be performed. So what we did was to run analysis on as many countries as we could. We had at the time data on 19 European countries, and indeed we did not find support for the hypothesis that at the macro level, where more intergenerational solidarity goes on, also the spread of a virus is higher. The reality unfortunately proved us true. Indeed, the spread of the virus became a pandemic level, meaning that all countries have been affected, and we could not find anymore a correlation between these two aspects. So from that point on, we started to think that we should be very cautious against over-interpreting available empirical evidence, and that we need to somehow put together different pieces of a puzzle in order to have a more complete answer. And we want to do this also in terms of individual level intergenerational relationships. So on the one side, we have evidence that people changed their behaviors. Grandparents stopped to look after grandchildren in many cases, and also at different points in times, mainly corresponding to new waves of the virus. We do have evidence that this brought together an increase in depressive symptoms and the lowering of quality of life. But family relationships are not just based on physical contacts. So somehow we can also think that family relationships can also help limiting the spread of the virus, not necessarily through physical contacts, but through their instrumental and social control functions. The literature has told us since many years that family members somehow complement the role of healthcare systems because they provide support, information, motivation, for example, to seek early treatment in case of symptoms. So if we take back this literature, we can start thinking that, okay, we know that more contacts, physical contacts, means more spread of the virus. But what does it mean when people are embedded in close kin relationships? They might avoid physically meeting them, but they still have support, they still provide control to each other and help each other. Instrumentally, so for example, going shopping for those who are more at risk, but also through provision of information and through a push, in a sense, to comply to a range of measures that have been taken to fight the pandemic. For example, wearing a mask. Based on this background idea that we had in the most recent work with both Bruno Arpino and Giorgio Di Gessa as well, we are wondering whether compliance to COVID-19 precautionary behaviors and vaccination acceptance might be actually associated with having close kin networks. Now, you can think this is a very complicated question to be answered, especially in the way we might operationalize these close kin networks. So we decided to keep it very simple at start. And what I'm presenting you today is somehow the effect of having a partner and children on compliance to these precautionary behaviors. We might think of a variety of further development of this operationalization, and I'm happy to discuss it further after the presentation. To do this, we don't use ELSA, we use SHARE. The reason is that it includes the variables that allow us to operationalize the concepts that we propose in our research question. Somehow there are parallels between these two surveys. As you might know, SHARE, the Survey of Health, Aging and Retirement in Europe, is somehow a sister study of ELSA, run in many European countries, and also as ELSA, SHARE has two so-named COVID waves. In this case, wave 1 was run in June-August 2020, and wave 2 in June-August 2021. Also in this case, in order to control to pre-pandemic characteristics, we used the most recent available pre-pandemic wave as well, which is SHARE wave 8, so that we can also have several variables that in the specific COVID modules were not asked, or indeed pre-COVID conditions. We come up with a sample that, depending on the outcome, we are considering goes between 27 and 33,000 respondents aged 50 plus, and we run a series of logistic regressions on the variables that I'm presenting you right now. What do I mean with precautionary behaviors? I already mentioned wearing masks. SHARE includes also other outcomes, so washing hands more often, sanitizing hands, covering cough and sneezes, keeping distance, physical distance, going less often to shopping or walks, reducing the amount of meetings and visits. To give you an example, here I have copied and pasted the variable on mask wearing. How often did you wear a face mask when you went outside your home to a public space? Always, often, sometimes, never. In our case, we categorize these variables as binary, having 1 if always and 0 for the other cases. Similarly for washing hands. In addition to these precautionary behaviors, there is also a question on whether the respondent is vaccinated against COVID-19. And here the answers are yes or willing to, undecided, and unwilling to get vaccinated. There is, as I mentioned, also a list of activities like shopping, going for a walk. And here we have information on whether people have changed their behaviors in this respect as compared to before the beginning of a pandemic. As I mentioned, we keep it simple, at least for now, and we consider whether the respondent has partner and children, whether the respondent has partner but no children, and whether the respondent has children but no partner. This is for now our central variable, and in all the analysis we control here as well for the usual suspects: age, sex, education, working status, household income, self-rated health, as well as diagnosed illnesses, GALI, respondent or close relatives that have tested positive to COVID, and having here a cross-country comparative analysis, we include also controls for countries. Here we have the result presented graphically because we have a larger variety of outcomes. So I'm trying to walk you through these results by highlighting the key points. So here we have basically 29 estimates. These are average marginal effects with their 95% confidence intervals. And we see that 16 of them are significant. And where we do see significant results, these are positive. What this means is that respondents who have close kin available, partner and or children, are more likely to adopt precautionary health behaviors compared to respondents who do not have close kin. Let me give you an example on the following slide. So here we see that partnered older adults or older adults who are in a partnership, independently of whether they have children or not, are about 6 percentage points more likely to use special sanitizers for hands or disinfection fluids. So was the question formulated more frequently than before the beginning of a pandemic. So what is interesting here is that this works for almost all these precautionary behaviors. And what we need to point out here is that the effect is especially for having a partner. So the role of the children is not really visible. Indeed, when we compare having a partner and children with having a partner and no children, the effects are very, very, very similar. While we do not see the same kind of effect for having children and no partner. So somehow, and actually in line with previous literature on this topic, there seems to be a stronger effect for having a partner than for having children. The only situation where we do observe a larger effect of children is in terms of reporting less shopping. And here we can think of a practical instrumental help of the children, which are younger and which might have been willing to take on shopping for the parents during the pandemic. So in this case, we do see a more clear role of the children. For what it concerns willingness or actual behavior of vaccinating for COVID-19, we do see basically the same story. So older adults that are in a partnership are less likely of either being undecided about the vaccination or of not intending to get vaccination. Again, here parenthood does not seem to matter much. You might wonder whether there are differences across the sample. We, of course, run a variety of robustness checks, conditional analysis, for example, distinguishing different age groups by gender, by country. In general, I can say that that the results are overall very, very similar to the main analysis that I have reported, especially by age. We do not see much differences or any significant differences. By gender, where there is a significant difference, we do see larger effects for men. We might think of interpreting this in terms of a stronger importance of family relationships for men's healthy behavior, so contextualizes in this kind of literature. And by country, we could not run a country-specific analysis because we came out to small sample sizes, but we could at least group countries in the somehow usual way. And here I would not add much because in terms of interpretation of these results, we need further investigations. On one side, we might hypothesize differences in terms of the importance of the role of the families, but we should not forget the variety of policies and suggestions used in different countries at different times are so wide that it will be very tricky to start this kind of discussion. But indeed, we might run some further analysis and maybe compare measures across countries at the time of the survey in order to get some further hints. What do we conclude here? We conclude that having close kin, partners especially, but also children somehow, imply a higher probability of anti-COVID precautionary behaviors, or at least we never found negative effects. So somehow we do have another side of the coin. So family relationships might play a spreading role in the COVID pandemic when it comes to physical contacts, but they might also, through support in other ways, be an advantage for older people in terms of taking on precautionary behaviors. It is in particular to highlight that having a partner is more important in this respect than having children. This confirms what previous literature in the area was suggesting, but we should make a warning here. In this simple analysis, we are somehow making unequal comparisons because we know that among older people, those who have a partner mainly live with this person, while those who have children mainly do not live with their children. So the aspect of co-residence might indeed play a role. We have also in this case started to run robustness checks and controlling for geographical nearness, so co-residence, and so far we did not find different results from the main analysis. So it seems to be very robust what we found also when we go deeper into the exploration, but it should at least be named as a warning. All in all, having presenting these two sides of research on similar topic, we could say that interruptions of face-to-face interactions increase the likelihood of poor mental health among older people, but at the same time, if a kin network exists and is there to support each other, even at distance, then there might be benefits for the older people themselves and at the societal level in terms of limiting the spread of the pandemic. Our hints from this work are that when deciding on restrictions or on suggestions in terms of how to reduce the spread of such a virus, then we should always not forget the possible consequences of these restrictions, whether direct or indirect, also on other aspects than the virus spread itself, and that in taking on this kind of decision, it is sometimes necessary, at least to differently address different groups of the population in order to make the best out of these suggestions and policies. And I think I stop here, and I thank you very much for your attention and looking forward to your comments or questions. Thank you.